السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم. أعزائي الطلبة, this is a second lecture about the inner ear disorders. Congenital inner ear disorders. Congenital or hereditary disorders of the inner ear present with congenital deafness. They may be associated with external or middle ear abnormalities or may exist with their own. The most common anomaly is dysplasia of the membranous labyrinth. Dysplasia of the bony labyrinth and rarely total aplasia of both may occur. Rubella is the best known intrauterine infections, TORS infection, toxoplasmosis, rubella, cytomegalovirus, herpes, and congenital syphilis that can cause inner ear damage. Perinatal hypoxia or anoxia and RH incompatibility are also risk factors of hearing loss. In such cases, cochlear implantation وهي عمليات زرع القوقعة can give excellent results. Labyrinthitis is an inflammation of the inner ear. Route of spread of infection to the inner ear either by, number one, middle ear infection. One of the most common complications of otitis media is labyrinthitis. Number two, intracranial sepsis. The cochlear aqueduct provides a direct communication between the perilymph and the CSF. Therefore, there is a significant risk of developing meningitis. Number three, via the bloodstream. This picture shows the direct communication between the perilymph and the CSF in subarachnoid space. So meningitis can cause labyrinthitis and even bilateral labyrinthitis, and vice versa, labyrinthitis can cause meningitis. Symptoms of labyrinthitis. Usually, patients with labyrinthitis present with severe rotatory vertigo associated with nausea and vomiting, and the duration of vertigo about days and even weeks. This vertigo associated with hearing loss, with sensorineural hearing loss and tinnitus. So patients with labyrinthitis present with triad of vertigo, sensorineural hearing loss, and tinnitus. Treatment of labyrinthitis by bed rest, labyrinthine sedative, and treatment of the underlying cause of labyrinthitis. Temporal bone fractures. Essentials of diagnosis of temporal bone fractures: history of blunt, severe, significant head injury, symptoms of hearing loss, vertigo, and facial nerve paralysis. And the signs of temporal bone fractures are Petal's sign, hemotympana, which means the blood within the tympanic cavity, and bloody otori. We have two types of temporal bone fractures. Number one, longitudinal fractures. 80 to 90% of temporal bone fractures are longitudinal. They involve the external meatus, roof of the middle ear, and the Eustachian tube. Usually spare the labyrinthine. Usually there is no involvement of the inner ear or the labyrinth. And the hearing loss tend to be conductive due to ossicular dislocation or disruption, bleeding into the middle ear cleft, hemotympana, rupture of the tympanic membrane. Bleeding from the middle ear and CSF otoria can result. Facial palsy is uncommon in longitudinal fractures. The second and less common one is the transverse fractures. Represent 10 to 20% of temporal bone fractures. Usually involve the labyrinth, so the patient has hearing loss which tend to be permanent sensorineural hearing loss because of the involvement of the labyrinth, and profound vertigo, which tend to settle in a time when central compensation occurs. And about 50% of cases, there is an associated facial nerve paralysis. This picture of the skull shows the longitudinal fracture along the long axis of the vitreous part of the temporal bone, and the transverse fracture which transect and vertical to the long axis of the vitreous part of the temporal bone. The signs of skull base fractures are periorbital ecchymosis, raccoon's eye تشبه عيون حيوان الراكون, the mastoid ecchymosis, battle sign, and hemotympanum, which is a bleeding within the tympanic cavity, and this is a blue drum, which indicates hemotympanum. And this is the Battle's sign, ecchymosis over the mastoid process. Diagnosis of temporal bone fractures. Temporal bone fracture must be suspected if there is any bleeding from the ear following head trauma. So any patient with head injury associated with the bleeding from the ear, bloody otorrhea, we should exclude fracture of the base of the skull. And the clinical assessment will demonstrate associated damage to the hearing mechanism and the cranial nerve involvement, especially facial nerve paralysis. So we do CT scan of the temporal bones to see the type and extent of the fracture of the base of the skull. This is axial CT scan, shows the longitudinal fracture of the temporal bone, and this is the axial CT scan, shows the transverse fracture of the vitreous part of the temporal bone, and here the fracture involved the labyrinth. The drug ototoxicity. Ototoxicity is the partial or total reduction in the vestibular function caused by the interaction of chemicals, commonly therapeutic agents, with the vestibule, cochlea, or the vestibulocochlear nerve. Either may be reversible and temporary, or irreversible and permanent. The most common ototoxic agents are, number one, antibiotics, especially aminoglycosides. We have either cochleotoxic aminoglycoside like neomycin and kanamycin. Cochleotoxic means they are toxic to the cochlea, so the patient will have hearing loss and tinnitus. And the vestibulotoxic aminoglycoside like gentamicin and tobramycin, which are toxic to the vestibule, so the patient will have vertigo and anesthetins. Another antibiotic which can cause ototoxicity is the erythromycin. We have a statement address that the untreated infection, otitis media, is a greater risk to the hearing than the antibiotic. This statement means that the risk to the hearing from the infection is greater than the risk of the ototoxicity. The second one is chemotherapeutic agents like cisplatin. Number 3, loop diuretics, furosemide, Lasix, and ethacrenic acid. Number 4, non-steroidal anti-inflammatory drugs, aspirin. 5, beta blockers like Inderal. 6, anticonvulsant, phenytoin. 7, anti-malarial drugs like quinine chloroquine and hydroxychloroquine. The synergistic effect. The dangers are especially great if excretion is impaired as in renal function. This statement means the risk of ototoxicity is greater in patients with impaired renal function. Symptoms of ototoxicity include partial or profound hearing loss and tinnitus in cochleotoxic drugs, and vertigo and unsteadiness in vestibulotoxic drugs. Treatment of ototoxicity. There is no specific treatment may be available, but withdrawal of the ototoxic drug as early as possible may be warranted when the consequences of doing so are less severe than those of ototoxicity to prevent further damage to the inner ear. We should do regular pure tone audiometric monitoring, and if the patient has profound hearing loss, we provide him with hearing aids, and the vestibular sedative, labyrinthine sedative are used for the vestibulotoxicity plus vestibular rehabilitation exercises. The quiz of this lecture. What is the pathology in this picture? Write a short note about it. Good luck.